Great. So for this opening keynote of today, I'm very happy to introduce Deborah Estrin, the Tishman Professor of Computer Science at Cornell Tech, where she's also the Associate Dean for Impact and the founder of the Health Tech Hub. Deborah, as many of you surely know, has made major contributions to a number of areas: networking, embedded sensing, and recently on health tech with its interaction with small personal data. For this, she's also been recognized by a number of awards. She's a member of the National Academy of Engineering and a MacArthur Fellow. And I know we're all very much looking forward to her talk. So Deborah, please go ahead.
Thank you so much, John. I'm honored to be asked to address this particular community that I look forward to be engaging with in the future. So I want to start with giving some context for this particular topic, and I'm going to advance my slide. I assume it worked. And it's a messy slide where I just borrowed a bunch of sort of eye candy from the title, the covers of National Academy reports that have been done over the years. And the context that it gives is really something that we're increasingly, and everyone is aware of, that there are just pressing public health challenges in recent decades, and they've illustrated how high the stakes are for intervention in the health sector, from upstream factors such as food and housing to downstream factors such as inequitable access to clinical care itself. And of course, the once in a generation, or I guess we hope it's once in a generation, or it's not just once in a generation so far, the COVID-19 pandemic that has widely recognized as being so exacerbated by tragic governance failures, at least in this country. So in that context, home-based healthcare in particular has become really a mainstay during the pandemic to reduce exposure. But the need for at-home care long predates it, right? Particularly due to our aging population and the burden of chronic conditions, from diabetes to cancer, which is increasingly a chronic rather than acute, and dementia. So we live long, but not necessarily healthy lives. And on a somewhat positive note, during the past decade in the US, we've also experienced a faltering shift towards value-based payment reform, and value-based care and population health lenses increase the possibility that the healthcare enterprise would actually accept, maybe even embrace, innovations in caregiving and more generally in these social determinants of health that are often referred to as upstream interventions. So starting in the days of flip phones and Palm Pilots, I joined the mobile health community in addressing this really outside the clinic healthcare. So there's a lot of important technology and many important problems that have to do with bringing technology in the service of the clinical enterprise, inside the hospital, inside of clinical encounters. Our focus has been on where life and therefore health happens most, which is outside of those clinical encounters. And in particular, in things like developing digital biomarkers, it's about interventions, and it's even about therapeutics for chronic disease and modifiable risk factors and behaviors. And there are a ton of interesting and important problems in that community. And we generally refer to it now, it's more broadly referred to as digital medicine. So I chose to use this opportunity to speak about a particular aspect of that space that, as I told the organizers when they asked me, that I haven't spoken about before. So that's why I also couldn't tell them exactly how long this talk is. And that's in particular this, as I titled it, Tech for Caregiving, because I think it's one of the areas that demands an acute social good lens to address it, and because I'm increasingly interested in the ways in which technologies can advance it. So When I first started focusing on health applications of mobile sensing, and that's almost 15 years ago, I was motivated to explore tech for aging since my parents at the time were in their 80s, and as it turned out, entering their last decade. But even though they both had PhDs in electrical engineering, introducing new technology for their independent use largely failed. And I wandered off to focus on the use of mobile technology and small data and such for individual care by more digitally native populations or demographics. In contrast, my real doctor sister quite effectively used the tools that they were accustomed to of the time, fax, telephone, email, and she used that to bring her medical and familial expertise to engage the caregivers, which was first my father who was my mother's primary caregiver, and then eventually a professional, a home health aide. And she used that technology to engage with the caregiver rather than trying to use technology to engage with the care recipients, my parents themselves. And recently, I've been inspired to come back to that and explore new technologies for caregiving, particularly by some of my colleagues around me at Cornell Tech. First and foremost, my colleague Nikki Dell, who studies the work of home health aides and has been for the last few years with some colleagues from Weill Cornell, Madeline Sterling in particular, but also by the rapid evolution of machine learning-based computer vision, natural language processing, personalization, and particularly mixed reality capabilities that I'll talk about more, I see as really having the opportunity to provide superpowers to caregivers. And also a reason to come back to the space is by the growing appetite to frame technical problems and solutions with values front and center. That's clearly evidenced by this MD4SG community itself. And it's so critical because that values first perspective is essential to the design of a technology that resides in our most intimate setting, the home, and during our most vulnerable times. And certainly as we age or when we're ill is clearly that sort of a time. So with that lengthy lead in, there are 2 points to my talk. First, caregiving in the home outside of a clinical setting is important and could really benefit from digital innovation with attention to key values that I'll talk more about. And second, to recognize that there are ecosystem challenges that we have to navigate. In the US healthcare system, there are misaligned incentives that interfere with improvements and innovations in public and individual health. And in the tech ecosystem itself, there's insufficient attention to problems and solutions that fail what I'll snarkily refer to as the OWS test, the obsession with scale test. And we fail from a business, we fail to apply enough investment, enough of our research cycles to problems that from a business perspective or from a data perspective don't exhibit tremendous scale. And I'll come back to rant about that at the end of the talk. So also just before finally advancing off this slide, some caveats and callouts. Caveat is that I will focus on caregiving for an aging population and in the US. Clearly, aging and caregiving is a global challenge, and hopefully there's broader applicability than just the US, but for any authenticity here, I want to talk about what I know better, and there are so many challenges here as clearly illustrated to all of us and to the world by our, by what's been happening during COVID. There is the opportunity clearly for applying some of these innovations to not aging, to the young, to adult populations. That's just not my emphasis. And I should also say as a caveat, I mentioned this is new work. What I'm talking about is largely aspirational. And then in terms of call outs, some wonderful colleagues I've mentioned already, Nikki Dell. We co-advise 2 PhD students who contributed very much to these slides, to this work, Emily Tsang and Andrea Quadro. And of course, many prior tech researchers who started working in things related to tech for aging and caregiving long before now. So earliest work by Eric Dishman, who was at Intel at the time, and I think he was at least one of those title slides that's in front of you is a report that he was heavily involved in. People at Georgia Tech, Gregory About, and many others at CMU. I remember long ago hearing a talk by Anin Day on the topic. University of Washington, Oregon Health Sciences, Misha Pavel, early and important work there. And more generally, the NIH, National Institute for Aging, Robert Wood Johnson, even AARP has a lot of interesting work in this space. And if you're interested in this space, National Academy Press is often a great place to go to get a good sense of how people are thinking about that space, whether it's for the context or whether it's discussion of technologies. Okay, so for the rest of the talk, I'll spend a few more slides just talking about the context of caregiving, and then I'll talk about technical opportunities, and I'll end with some discussion of the values context, both in the designing technologies and within the ecosystem. Okay, so caregiving for older adults, the caregiving landscape. The statistics in the US are very clear. Over the next 40 years, we'll have the percentage of older adults grow from 15 to close to 25% due to life expectancy. Well, okay, these data precede COVID from the Bureau of Labor Statistics, and declining birth rate. And secondly, home care really matters. So whether you're looking at cardiovascular disease, recovery from a heart attack or stroke or metabolic disease, from obesity, diabetes, COPD, cancer, dementia, all of these call for a lot of health and medication adherence at home, for helping people with activities of daily living to keep active, for contending with confounders of declining abilities, particularly with respect to aging, whether that be hearing or vision or cognitive, and lack of attention to those issues early on, lack of attention to issues that arise early on at home can lead to much bigger medical problems and higher aggregate medical costs, medical bills for an individual family, medical costs for the overall healthcare system. So home care really matters. Another point about caregiving and caregiving for the aging that struck home with me when I was speaking a few years ago with a gerontologist researcher, Hiroko Dodge, and she said that, you know, when we're born when we're first born, babies are relatively similar to one another. Sure, there are the genetic differences that we're born with. But if you think about it over the years, and by the time we're in our 70s, 80s, and so forth, we are so differentiated because of our life experiences, our environmental exposures, what we've eaten, the healthcare we've received, the stresses we've been exposed to where we've lived. And so looking at caregiving as a place that needs that kind of personalization that comes into technology is particularly motivated because of that level of differentiation. And caregivers themselves, I'll say more about this in a moment, are also being recognized as a very important population. And that's true for the family caregiver and the professional caregiver. And for the most part, when I'm talking about caregivers, I'm speaking across those, and at times I'll refer specifically to one or the other. So what is the home caregiving experience for those of you who haven't had that experience yourself with older adults in your life? Whether it's family or professionally provided, it's very heterogeneous and it's changing needs over time. There are clinical things like adhering to medication, actual recovery from a surgery or a acute event like a stroke or a heart attack. There's the activities of daily living, good hygiene, good nutrition. And there are, of course, the upstream factors such as available housing and available healthy food and things like social isolation. And so caregiving is a combination of very routine and repetitive, and then occasionally unusual and urgent. And if you think even just about being discharged from a hospital, that is a time for older adults when sometimes the most intensive or most systematic caregiving occurs is when a discharge happens from a particular event or surgery. And at that time of discharge, there are a ton of instructions to follow. Maybe they were given to you by a discharge nurse or primary care, or maybe you're lucky enough to have a care coordinator call you up sometime after discharge. There's all kinds of prescribed patient monitoring, checking symptoms, checking, a pulse ox, which we should all have at home in the day of COVID, temperature to check for signs of infections, different follow-up care, looking at a wound to see if there's any sign of infection. And there are other dimensions, as I mentioned, from hygiene to getting somebody increasingly active. And alongside these routine types of care, there's vigilance to catch any new concerns that arise. And they could be due to things like some side effect of a medication, or they could be due to depression. So I do want to call out professional home care in particular, because that is a very important part of the story and an important motivator for me and for my colleagues. And as I mentioned, my colleague Nikki Dell is really who brought me to this space, is that the population of professional home caregivers do really difficult, very important work, but that is often undervalued. It's undercompensated, and it's not invested in with training and tools that in a way that actually reflects how important it is to the individual recipient of care and to the family of that individual. Caregivers work long hours for clients, some of whom have serious illnesses. It's difficult, it's unpredictable, the work. And you really have to be ready to respond to whatever the client may need. It could be life or death, or it could be really mundane. And the majority of this workforce are women, usually Black or Latinx, and wages are low, often close to minimum. So it's a hard job, inadequately appreciated, invested in, and it's really growing as the need for such care grows. Also want to say that workers often have an insufficient pathway for not just for training, but also for advancement. And so one of the opportunities in this space is how can we make the work and address the quality of work alongside addressing improving the quality of care. Okay, so where might tech help? So I'm a technologist, and I'm assuming that many in the audience are. We design new algorithms, mechanisms, systems, capabilities, And there's so much that can be done to improve caregiving now with the tech that we have. And that's important and something I care a lot about and am interested in spending more time on. But what I want to talk about in this talk is some of the design opportunities as we work on the future generations of technology for this application domain. So, and those sorts of technology opportunities exist across many aspects of caregiving, whether it's recovery or adherence or activity of daily living, and so forth. And I'll spend the next few slides talking about in a little bit more detail in each of these areas of interactive remote guidance and interaction design for confounders of aging, and in integrated ethics in particular. And just before I do that, I absolutely acknowledge that this is a messy space for CIS researchers. It demands domain expertise, not necessarily in the CIS researcher, but in the collaborative team. It sort of demands a tolerance for what many years ago I heard Margaret Martinosi on a panel talking about multidisciplinary research. This was back when she was developing technology for monitoring zebras. And she talked about when you're doing mission-driven work, you have to be willing to take turns. Sometimes you're working with a stable technology to advance the practice and collect data. And then sometimes you're able to use that data and understanding the practice to advance the underlying technology. So all of that is the case with this kind of work. It also fails as sort of a precondition for attracting some of the innovation ecosystem in that it neither has existing large-scale data sets in many cases, nor a clear, large addressable market if you're looking at this from a commercial perspective. And perhaps the messiest or odd aspect of it, in the way I am framing it, is that in my opinion, we need not and should not be removing labor from caregiving in order to pursue the best individual and societal outcomes. So I think for the most part, when resources are no option, when people have plenty of resources, when they're wealthy, they don't leave their aging parents or aspire to leave their aging parents or their vulnerable children or even their pets alone or with a robot. They're not likely to prefer robots without people anytime soon. So I'm just leaning into that. We have plenty of people in need of gainful and rewarding and fulfilling work. I see no reason to design them out of the equation. Can always bring in robots for tasks like heavy lifting and such, but I see that as complementary. And finally, even the most ardent automation AI evangelists throw humanity the bone of humans are good at empathy. So again, I'm just leaning into this definition of the caregiving problem as one in which you might have people aging in place, but not alone, that they have a human caregiver that is a part of their lives. So one sort of guiding vision is to create an immersive care system to really give local caregivers and give them the ability to be guided and advised by remote experts as they provide care at home. So caregivers are, whether they're family members or home health aides, they are and they become the expert on that individual in their day-to-day and how they're doing and what their needs and preferences are. But particularly with aging, things come up. Healthcare issues come up, whether they're a halted or a paused trajectory of recovery, or whether there's a sudden decline cognitive, or it might be due to onset of an infection or some new condition. And the range of things that can happen are wide and varied, and there's no level of training of an individual home health aide that is ever going to address that, as well as wanting to and needing to reach out to a medical expert, from a physical therapist to somebody who's a more general geriatrician, to a physiatrist who deals with pain. So motivated also by colleague Serge Boulanger, who works in advancing computer vision capabilities to support augmented reality. We've been collaborating for a while. We were very early on at Cornell Tech together. And I used to tease him about using a smart kitchen application as sort of the motivator for his augmented reality work. And but of course, in retrospect, those are actually excellent stepping stones to work on what we're now calling immersive care. The ability, so just as illustrated in this great picture done by Christina Coe, who worked with me, just envision the caregiver at home with an older adult who's doing rehabilitation. Maybe it's for a rotator cuff problem, maybe it's due to recovery from stroke, and daily rehab is critical. So whenever patients can, they go to a professional physical therapist. They often do that with their caregiver to learn what needs to happen, but everybody needs to do daily rehab to try to regain as much function as they can. And those exercises are adaptive. As you can do more, they need to progress. And it's critical that they be adaptive and do that. Well, imagine that as you're doing this physical therapy, you might be using a video or avatar-based system to help the home caregiver and the patient pursue those exercises. But things happen. So at some point, the patient might no longer be able to do what they were able to do yesterday, or no longer able to make progress. Maybe they're suddenly experiencing more pain and they start to plateau. At that point, you'd like to call out to an expert who, by having an immersive view of what's going on between the caregiver and the care recipient, can tell them, you know, if you adjust, the shoulders are hunched, if you adjust how you're holding them, and that needs to happen with a kind of projection system, augmented reality, onto the torso, a system that can view a grimacing face and interpret that as a pushback on level of pain, and a system that is also augmented with language-based instruction to help explain to the caregiver and to the care recipient what to actually do. And then in this vision of the future, that's the sort of thing that once that's explained in future iterations of engaging in those exercises, the agent at this point, the system, should be able to continue to give verbal instruction as well as visual guidance on continuing to progress with those exercises over time. So that's this view of how immersive care through augmented reality and guided instruction, one that is personalized, one that adapts, one that learns, could really be a superpower for caregivers and care recipients at home. And whether that has to do with doing rehabilitation instructions, which was that example, or whether it has to do with helping an individual start to get out of bed and move around after surgery. That also is something that if you've ever been in that situation of trying to help somebody, if you're not trained, if you haven't been through it with 100 previous individuals, you're not as skilled in helping people do that and adapt to their, wherever their surgery might have been, wherever their pain might be emanating from. So that's this sort of vision of immersive care. There are also opportunities that are somewhat closer at hand or more focused. Things like collaborative Q&A agents for caregivers. So day-to-day caregivers, professional or family members face unexpected changes in patients' health. And when they need to, absolutely have to reach out to a real-time expert in the future through that sort of immersive care system. Now it's through telephone or through Zoom. And but there are many questions. It's difficult to always get in real time to an expert. Of course, that's a limited resource. You don't want to have to be calling 911. That it always, for the family, for the patient, for everybody, needs to be the last resort. But you'd like to be able to bring our current technologies to improve the Q&A sorts of systems that could exist to help fill this gap. So many opportunities in designing conversational agent techniques to fill that gap, whether it's noticing some level of swelling, and which is a concern always in, for example, heart failure patients, and is that level of swelling normal, whether it's with visual image inputs or whether it's just some sort of a description. The opportunity to have a full agent back and forth to answer those day-to-day questions are clearly there. Some of the challenges are doing that with interpretability, so that clinical experts develop and confirm confidence that the answers being given are being done with safety. And things like problems that people work on in other spaces, such as in other contexts, such as recognizing and repairing misunderstandings, clearly critical in this space. And also recognizing that this is a multi-person story, so supporting human AI collaboration. There are multiple caregivers. There's opportunities here for and issues of handoff between home health aides and the family members, between family members, and the analytics and the data and the contextual understanding that can come from what has been going on in the Q&A system. That itself is a rich source of data that can help to provide additional context. A third area ripe and rich for research here are voice-based conversational agents for older adults themselves as well as for their caregivers. So Andrea, who I mentioned earlier, the PhD student working in this space, looks at IVAs as being so beneficial for older adults for many reasons. First, as was recognized, and you probably all saw that Saturday Night Live skit about the use of Alexa, speech is a natural way to communicate for many. And so it can be simpler to use than purely text or some graphical interface. And as Andrea is studying, there are many interesting opportunities there. The ability to create synthetic voices that sound familiar to the individual, and it's easier for them to understand, whether it's familiar accents or vocabularies. Also, the ability to accommodate multiple impairments, because you can use visual displays which help for people who have cognitive impairments. When you just hear things through sound, they're very ephemeral. And you might want to build a system that's an interactive voice agent that is a combination of voice, but also screen-based for visual reminders. And these voice-based conversational agents, as I said, can be relevant for the caregiver, who often might have their hands busy doing something and helping the care recipient, as well as for the recipient themselves. There are all those frequently asked questions we always talk about, and when somebody is older and perhaps cognitively or memory impaired, there are the very frequently asked questions. And so the opportunity to build technology and agents here that are patient, and particularly patient, is also important. So I wanted to transition to the end of this by talking about values. And I like to start in, I like to include in these talks on health a reference to just such a brilliant and articulate person in the health space, Atul Gawande. And in the first book of his that I ever read, again, highly recommend him to you, called Being Mortal, he wrote, "The battle of being mortal is the battle to maintain the integrity of one's life, to avoid becoming so diminished or dissipated or subjugated that who you are becomes disconnected from who you were or who you want to be." And so designing technology for aging and for caregiving is just essential to bring to it a values in design perspective. And so particularly, in particular, some of the challenges that we don't have addressed, but that we are looking at, and that I think many could, not at all an exhaustive list, is, as I said before, starting with the value of human caregivers, that the value of perhaps aging in place, but not aging alone, and the value of that last meter of care being human. And so collaboration, augmentation, training, quality of work life, rather than replacement. Designing automated agents around human collaboration and learning, and balancing the sort of bot accessibility and natural interactions with some and the natural interactions that comes with something that is human-like, so being able to interact with something through voice. But on the other hand, I'm not so sure how much we want people to think of the agent as being human. That there are interesting questions here around trust and authenticity that, as Andrea's thesis is called, the title is Illusion of Empathy. There's a double-edged sword. It's a double-edged sword, these human-like agents, and I think will make for some really interesting design considerations going forward. Second, the patients and those being cared for are vulnerable to neglect and abuse, but they're also vulnerable to compromised dignity and agency. And this is a place where contextual integrity, developed by my wonderful colleague Helen Nissenbaum, a framing for how to think about privacy as contextual integrity, and considering what are appropriate data flows that are consistent with aging and with caregiving. A third one is quality of work life that I've mentioned. How can we use this technology to increase the quality of the work, the opportunity for learning and for advancement, for reduced isolation that happens to the caregivers themselves, and particularly for professional home health aides who do their work without visibility, without peer support, without the opportunity to become peer supporters. There's so many ways in which digital technologies could improve their ability to see and be seen, to learn, and to advance. And finally, from a values perspective, addressing these broader set of needs is not really aligned with our innovation ecosystem's obsession with scale. As I said, I would return to that. So designing for linear labor costs is not a venture capitalist or even a public health expert's idea of a good investment or a scalable approach. And yet, I think it's what we most want for caregiving. And designing data flows with contextual integrity also adds friction to scale. So when we want to respect the data access, respect the flows, rather than necessarily create monetizable and mineable data sets. So these are really, I think, intriguing, important, and rich problems, but I can't call them low-hanging fruit. They're not easy. So as my last slide, I just want to broaden out and close with this point about the values in our ecosystem more generally, and that there is this gap, as this community well knows, and that's why this community exists, between the social and public interest demand and tech sector supply. And caregiving is just one example that's insufficiently addressed by the innovation ecosystem. The innovation ecosystem in digital health has seen a lot of attention to technology to help with medical expertise and to some extent with self-care. So it's easier to create products and markets that you target an individual to take better care of themselves. But there are many quality of life improving innovations that just fall outside of the traditional investment models when you're trying to think about them, and you have to think about them in that world based on total addressable market and return on investment. And that's particularly with respect to respecting data, and also with respect to just where the healthcare system doesn't really doesn't present a buyer who is going to buy this technology because it reduces their costs or gives them opportunities for increased revenue. There are lots of positive externalities around prevention and around care. And I would hope that our ecosystem, our tech ecosystem, can find more ways to make room for those sorts of innovations. And it's not just the commercial sector that underinvests. The academic research community is also biased towards scale. In particular, students and researchers and publications are generated where the larger data sets are. That fits that machine learning publication flywheel. And this space doesn't have those existing data sets in the same way, and that's a struggle. So to conclude, advances in immersive care technologies could really catalyze transformation in caregiving to support aging with integrity. And if done right, those transformations could enhance the lives of both aging adults and the people who care for them. And doing it right requires values and integrating values into our designs and our tech ecosystem. And the tech we develop, and to have the tech we develop reflect our societal values, and to grow the portfolio of what is increasingly referred to as public interest tech innovations. And to do that, we need to broaden the range of business models very intentionally and make room for alternative drivers and shapers of what makes an interesting problem and solution. So with that, I'll end. Thank you.
Thanks very much, Deborah, for that great talk. One thing I very much appreciated in this talk really was sort of the linkages between your conception of public interest technology and some of the broader goals of the MD4SG community, and in particular the really compelling example that's playing out in. And as I see it, it certainly at minimum involves trying to apply computational ideas to crucial areas of compelling interest, where there's the need for increased access to opportunity, where there currently, for various reasons, is limited computational activity. And I think the end of your talk spelled out very nicely some of the ways that there might end up being limited computational activity, either because a domain, despite its compelling societal need, might not fit the dominant business model or even just the dominant academic research model. But I think this, in a sense, unfolds in two steps, of course. One is to recognize the opportunity for computational interventions. But second is to, of course, as you pointed out, think about the challenge of understanding the impact of the computational intervention, by thinking about the values in design, also by thinking about the technical obstacles and bottlenecks that means that the fit between the basic computational ideas isn't as direct as we might hope. I think the opportunity in your talk is clear. There are a lot of computational modalities through natural language, through computer vision, virtual and augmented reality. There's a set of core methodologies, and this is one of, I think, a number of exciting emerging areas where you see this interaction between core machine learning techniques and core human-computer interaction techniques, which I think has been a rich and fruitful topic. And then, of course, there are the broader implications, the privacy issues and the ethical dimensions. I want to just highlight two of those before we turn to questions. The first is, of course, just the challenges of data. And in general, problems in MD4SG or in public interest tech tend to benefit from the sophisticated use of data, and we often run into challenges in sort of how we're able to make use of that data. I think in the caregiving domain, there were sort of three interesting things I took from the talk. One is obviously the privacy implications. The second is this whole issue of treating people as individuals, which of course Atul Gawande spoke to in that quote very powerfully. I think from a more narrow technical point, there's even just the sort of tension between trying to use something like a machine learning pipeline, which involves a constrained set of features, with the problem that the actual whole individual may have important features that we need to know that's not in that constrained set. And finally, of course, you know, given that this is a domain that's very individuated, the benefits from sharing data across instances relies in a sense on a property of the domain itself, that there's actually sufficient commonality across instances for insights to transfer in this whole question of transfer. The other point that often comes up I think in MD4SG applications, as in this application here, is the one that I think you highlight very nicely as well, which is the mixed incentives that we have among the participants. These are always multi-participant systems. And one of the things, one of the very interesting insights to emerge from the sociology of work, which I first learned about from my colleague Karen Levy, is this notion of the service triangle. That when we think about any kind of work that's providing a service to an individual, there's this interesting three-way power relationship between, in the generic language of work, and it's not necessarily the exact right language here, between the customer, the recipient of the work, between the worker, and between the manager. And you can get these interesting, complex, shifting alliances between these three parties. I think if we adapt this to the realm of caregiving, first of all, we can try to look for those participants here. This picture is not the picture on the right is not actually a direct mapping to the picture on the left, in that the remote expert is in no sense the manager. In fact, I think, you know, one thing that's going on is each of these parties has some sort of manager that's in the background, which would add, you know, nodes 5, 6, and 7 to this picture. But there's also this system that's been dropped into the middle, this computational system, and the designers of the system whose incentives might not be aligned as well. And so I think that also adds to the complexity of the domain. So with all of this, I think, you know, we have sort of a lot of the ingredients that make these MD4SG applications so compelling. A societally important problem, which has so far received very limited computational attention, and some interesting challenges in the direction of both data and incentives that I think are going to give all of us a lot to think about. So thanks again for this wonderful talk. I guess as a first question based on this, I was wondering if you had thoughts on these data and incentive issues, and how you see them determining some of the course of of how the research unfolds.
Thank you, John. And just the opportunity to have this conversation with you is wonderful. So one comment, you raised many things. I want to address all of them. I went over with my talk to begin with, and that would have it go further. But in terms of this issue of the individuation of the older adults, and therefore how the tech needs to be, and this question of whether the data sets and the training can be representative enough, I think that's the nature of medicine, in the sense that there is that level of individuation, but medicine exists as a practice because despite that individuation, there is a theory and a commonality of the underlying physiology and the range of things that happen that allow a generalization of understanding. And so I think there is still a great opportunity for developing the training sets we need and for advancing those, some of which might happen through some of the work that goes on in terms of generated data, when you can generate many more variations on things using the same using machine learning tools to do that data generation. So I don't think it by any means is that a non-starter. I also expect that there are many ways in which we can design effective systems that, when they're deployed in the wild, still provide the caregiver and the care recipient with adequate privacy. Whether those are the most monetizable ways to build the system is another story. But the opportunity, can we technically do that? I think the answer is yes. We have a bootstrapping problem, which is those data sets. If I have a new PhD student coming in, I don't have those data sets for them now. We have to generate, and we can begin the process by having laboratories where we do data capture in the same way that we drove a lot of the original video capture and motion capture and all of that work before it was captured out in the wild. So there's a lot of progress we can make there. And I think this, on your second question about around the incentives, that designing for those incentives or designing despite those incentives are both challenges that for me, it gives me great hope that communities like this exist, that we will simply apply for funding in this space and have our students pursue these problems because they're the right ones to pursue. And there are no losers should this vision of the technology and ignoring those incentives come into be. Better caregiving, nobody loses by it. The problem is, how do we get there when it's not clear who financially wins in order to get that process started? So I think that's just a key role for academia and research to play, is to have the conviction to pursue these areas and to really make room in our attention space for things that fall into more of a public interest realm, where positive externalities exist and where we need to take on those problems, despite the fact that they're not going to be the ones that are picked up soon in this framing through the traditional startup venture capital or even large company product investment.
That's very interesting. And Reddy, since I think you were looking at questions from the audience, I wonder if you had a question.
Lynn Chiabo from CMU asks, have you seen instances where technology promotes the agency of a caregiver over the patient? How can we consider the agency of both, especially when their priorities might conflict in the design of technologies?
So I just want to point to my colleague Nikki Dell and her collaboration with Dr. Madeline Sterling at Weill Cornell. They had a highly discussed piece just a couple of weeks ago in JAMA, where they studied home health aides during COVID. So it's not that there's a technology piece that does that, but I think the beginning of the work that looks at the home health aide caregiver and that work environment and the need to balance the quality and the safety of care with the agency and autonomy and quality of work of the caregiver. They've done existing really good work on studying that work context. So I refer you to Nikki Dell, and email me if you're not finding the relevant publication that fits that.
Maybe I'll ask one more. So Crystal asks, how do you think technology can help with abuse of elderly in caregiving homes, which I think is a little bit related to what you just said?
Yeah, it is. And there are sort of simple ways of thinking about that, right? Which is, always on video or audio surveillance, and it immediately comes up against issues around privacy and dignity for the person being cared for, as well as that continuous, working in an environment of continuous surveillance, but for a home health aide. So I think there is plenty of opportunity to do it in ways that we would probably not want to bring into our aging, parents' homes when we think about it personally, but plenty of ways in which we could design systems that are collecting the right amount of information for the right level of surveillance, whether you're worried about patient safety or whether you're worried about abuse. So I think it's a very interesting needle to thread that, again, if you're not thinking about it from a business model perspective, from a technology perspective, we should be able to do some interesting work in that space. So these systems, I think, can improve the overall situation, but they very clearly present that possibility of doing it, if you would, sort of wrong in a way that is overly heavy-handed, and doing it right in a way that is more sophisticated and has more done from a contextual integrity perspective.
That's great. Thanks very much.
Very good. Thank you so much, Deborah. This was a really wonderful talk. I think it's a lot of the points that you raise are things that we think about in other domains, although I think many of us have not thought about caregiving, although it's a very complicated and incredibly important space. So it's been really wonderful to have you here and to learn from you and to have you as part of our broader community. So thank you for your time. And thank you to Jon for the discussant remarks and the questions.